One of the things that I worry about a lot is that we're very focused on this opiate crisis rather than the people. And really, addiction is a people problem, not a drug problem.
I don't believe that any form of drug use is good drug use, whether it's once a week, once a month, or once a year, because the side effects can still be there. I can still overdose. There is cause and effect when it comes to my family, perhaps, when it comes financially. If you are an addict, you can't use.
I actually know somebody who was looking for help, got told he couldn't make it for 3 weeks, that there was no beds available for him for 3 weeks. He ended up dying before that 3 weeks because he was still using. So instead of leaving them to die, how about we give them a place where they can safely use while they're waiting to get into those treatment centers? You're actually saving more lives.
From the Zoomerplex in historic Liberty Village, the Zoomer with Marissa Semkiw.
Welcome to the Zoomer. I'm Marissa Semkiw. Today we'll be discussing a problem that is so pervasive, so complex. It's left doctors, health officials, and politicians scrambling to find solutions. This year, some 3,000 people, or 8 Canadians per day, are expected to die of opioid overdoses. To put this into perspective, this is much greater than the number of Canadians who died at the height of the HIV epidemic in 1995. Now, while this crisis has its roots in the overprescription of opioid painkillers, deaths from illicit consumption of heroin and fentanyl are also on the rise. At the roundtable, I'm joined by several doctors and addiction specialists, as well as a former prescription opioid addict. We will break down everything you need to know about this epidemic. But before we dive in, let's tee up the topic.
Canada is in the midst of an epidemic of opioid use and abuse. Opioids are drugs that act on the nervous system and include commonly known types such as fentanyl, oxycodone, morphine, codeine, and heroin. All but heroin are prescribed pills. Canadians are amongst the highest per capita consumers of opioids in the world, second only to Americans. But while the U.S.'s numbers are in decline, Canada's are growing. According to Ki-High data, in 2016, there were more than 2,800 apparent opioid-related deaths in Canada. Opioid poisonings resulted in an average of 16 hospitalizations each day in 2017. Over the past 10 years, adults age 45 to 64 and seniors age 65 and older had the highest rates of hospitalizations due to opioid poisoning, 63% of which were accidental. The use of opioids to manage chronic pain is poorly supported by scientific evidence. Yet many doctors continue to prescribe them, often because they don't see a better alternative.
So, Gail, why don't I start with you? Walk us through how we got here. Because, of course, opioids have been used therapeutically and recreationally for thousands of years. But today there's a real crisis at hand. So what was the reason, what was the catalyst for getting us to this point?
So I think it's fairly well established that what got us to this point is drug companies that have promoted the use of opioids for pain management.
Like Purdue Pharma?
Purdue Pharma was one. You know, chronic pain is a difficult situation to manage, and opioids were seen to be a solution to this problem. The problem was that it got way overdone, and too many prescriptions were written. Continues to be the problem. There was also misinformation given to physicians about how much, and also the misinformation that these drugs, OxyContin and others similar, were not addictive. And so we saw a real boon in the prescription of those opioids to manage a legitimate pain problem. And here we are today.
In the 90s, Purdue, in the cynical view, was they realized that their patent on MS-Contin, which is a slow-release formulation of morphine, was expiring. And I believe internal documents have shown that the company was trying to think of ways to find a new market. And so they decided to market oxycodone, which is the main ingredient of OxyContin. And they told doctors, they went around, they told doctors, look, this is safe. It's going to help with the problem of chronic pain. And I think the other thing that they did, besides marketing aggressively to physicians, is pharmaceutical companies also work by marketing to physicians, but also by raising disease awareness. So they went around and they really promoted this idea that chronic pain is undertreated. Before that, I mean, people have always had chronic pain, but before that, there wasn't such an awareness of chronic pain as a disease in and of itself. So Purdue really aggressively promoted OxyContin, told physicians without any scientific basis that the risk of addiction was less than 1%. And we know it's much, much higher. And they continue to market it and tell doctors, like, this is safe for your patients. And when it became more apparent that there was a problem, Purdue really marketed it as, well, those are the bad apples. Those are the patients who aren't taking it as prescribed. And instead of recognizing or acknowledging that this is intrinsic to the medication, it became, well, the patients who are, crushing it or snorting it or taking more than prescribed, there's something inherently wrong with them. And this is an addiction issue. This isn't intrinsic to the medication itself.
So Anita walked us through sort of how we got to this point. But when you look at the data, we're looking at nearly 3,000, perhaps over 3,000 people dying in 2017 alone, 2,800 last year from opioids. Is this problem, to what extent is this problem prescription related or recreational related? Because there are two sort of distinct issues here, yet very overlapping, Keith.
Pain, when you're on particularly the opioids that have been prescribed, it masks it so well, you don't even know if you do have legitimate pain anymore. And the only way to actually come off of that or find out about your pain would be to come off of it 100%. Sometimes the coming off of it can be so painful that people don't want to come off of it to actually find out if their back is better or their knees are better after their surgery. So the prescription now becomes more recreational, to maintain, to get up out of bed, to be able to function in work, to have a conversation. I need to take X or Y prescription that I got before. So I can simply go back to the doctor and say, I'm not out of pain yet. And I will continue to take it, get more prescriptions. And a lot of the doctors would rather just write you a prescription rather than go through all of the steps that are necessary to truly diagnose whether you have an issue or not. And they don't, a lot of the time, have a plan to get you off of it once they get you on it. And that, I think, is one of the biggest problems.
We talked a lot about how we got to the point of people being addicted to the drugs and what Keith said about, not knowing if you have the pain. But what happens is when people, if physicians do cut back on their prescriptions, because they're being advised to do that now, they know it's good practice, people still don't want to feel the pain, and that's when they turn to other markets or other sources in order to keep it up.
Okay, when we come back, we'll discuss how the opioid crisis is hitting seniors hardest. Stay tuned.
When an individual is using it to maintain rather than to either cure or treat, that's when it becomes a problem. And a lot of individuals don't know when that actually happens.
Welcome back. In general, tolerance to a drug occurs when an individual, over time, requires greater amounts of a drug to continue to obtain the original desired and therapeutic effect. This phenomenon is true for opioid medications. As prescription opioids become less effective, patients have to keep increasing their dose. With an increase in dose comes an increase in other side effects, from nausea to paranoia to respiratory problems. Kathy Wardle was suffering from acute pain caused by a spinal condition. The pain was so severe that even with powerful opioids, she was unable to adequately control it. John Thornton, VP of Production at Zoomer Media, created a documentary about his friend Kathy's experience living with pain and opioid addiction, which eventually led her to take her own life. Here's a short clip.
This is Teva morphine. It's 60 milligrams. That's a long-lasting. It's supposed to last for 8 hours. So I had one this morning at 8 o'clock. I take one now, and I take one before I go to bed. So this is my middle of the day one. I put them all in a little container. This is some called Statex, and it's a each little pill is 10 milligrams. I can take 4 of them, so I'm cheating, and I'm going to take 5. because I really don't care. I'm suffering from anxiety, so I'm taking a 1 milligram tablet of lorazepam. Here goes. Even all that doesn't do the trick anymore.
Now, people don't tend to think of seniors when they think of opioid addictions. And yet, almost a quarter of all Canadian hospitalizations for opioid poisoning over the last 8 years were people over the age of 65. So as a doctor, is Kathy's story unique?
I don't think her story is unique. I think that, you know, obviously, as we age, we have more chronic pain, and so it is going to be a population that is going to be treated for chronic pain, and opiates are often being used as first line for chronic pain when they really shouldn't be. I think the other thing that's really important to point out is that we focus a lot on opiate overdoses, and we are in the midst of an opiate crisis, and I think that's very important. But beyond addiction, there are many harms that come from opiates, even for patients who aren't addicted to opiates. So even patients who are taking it exactly as prescribed, they're also at greater risk for things like sedation, falls, osteoporosis, sleep apnea, that's a whole host of issues, I think, that often gets lost, that we forget about when we're focusing on the opiate crisis, which is obviously, you know, very important and very front and center right now.
Now, Stephanie, you have a personal story to tell. Now, you don't come from sort of a prescription opioid.
Absolutely not. I've never had a prescription for opioids in my life.
So why don't you tell us a little bit about how you got to where you are?
Well, it started back when I was 22. I'd gotten wrapped up with cocaine, and that kind of was the gateway for everything. They say that marijuana is the gateway, but no, let me tell you, cocaine is. As I was going through that addiction, I caused problems for myself. My life was falling apart. My family was falling apart. This created a huge pain, and the cocaine wasn't taking care of it anymore, and I had my ex bringing in pills all the time, so that looked like a better option at the time, I guess. The mentality of an addict is not always the best thinking, but unfortunately that's the road that I went, and I ended up within 3 days, I was addicted to pills. I couldn't get off of them. I was sick when I was starting to get off of them, and I saw what happened to him when he didn't have them, so yeah, I wasn't too keen on jumping off anytime soon.
What we know about seniors is that I think it's 2/3 take 5 or more prescriptions. So it's not just the opioid itself that could be harmful, but it's the potential cocktail that they're on.
Well, in our organizations, we deal with use of drugs and the harms that they cause for many kinds of drugs. And one of the biggest issues is polydrug use. So whether they're prescription drugs or alcohol, which is still a huge problem and a bigger problem than opiates for seniors, but especially in combination, it's really lethal and very difficult to treat. But one of the things that I worry about a lot is that we're very focused on this opiate crisis rather than the people. And really, addiction is a people problem, not a drug problem.
I really like how you said that, because I think you're right, Gail. I think this really is about, it's a person specific. It's about people. And I think a lot of the conversations that my agency has been having is, yeah, how do we increase the quality of our conversations with the people that we work with? Mm-hmm. How do we start to have conversations that really allow people to share what they need to share, so that we're really getting at the complexity of this issue.
One of the things I really wonder about, Keith, is at what point does prescription cross over into addiction?
When an individual is using it to maintain rather than to either cure or treat, that's when it becomes a problem. And a lot of individuals don't know when that actually happens. You know, my mother, for instance, you know, before she passed, she would always say, I need to take this to go to sleep. Because it was instilled in her, the only way she's going to sleep is to take her sleeping medication. I need to take this, I feel anxiety coming on. Well, if we treat the problem, right? Rather than say, here's a pill to treat the problem, we can start to work with individuals. I think that that's one of the biggest problems that we have in our society right now is physicians are more willing to simply write you a prescription and say, this will solve your problem, rather than say, you know what, here are some tools and solutions to solve your problems, work on your problems, or minimize them a little bit so you can get past the immediate need to pop a pill to fix your problem.
Right. Okay, well, when we come back, are prescription opioids a gateway to recreational use? That's next.
The purpose of the injection site is to ensure safe use. So people are going to use. People are going to use under very unsafe circumstances, and so they're a life-saving measure.
They have all the resources there. You know, they have the nurses, they have the oxygen tanks, they have the Narcan. They know when they're going down. They're not in some cubbyhole, like dying alone. And you know, and they don't have to die, right? And so this is like that step, right? It's that thing that we need in order to save lives, and it is what it is. Yeah.
Recently, Health Canada approved 2 supervised consumption sites here in Surrey, an area that has seen the highest overdose deaths in the region.
So we have 2 sites here now located in Surrey, as you spoke about. One is run solely by Fraser Health, and that's the Creekside facility over near the Surrey Memorial Hospital. Behind us here is, I guess, the largest site supporting 7 people at 7 booths a day on 135A Street.
Because I've got to go to detox and then go and do recovery.
I've lost lots of friends here. Like a big sheet of paper down there that says a bunch of people's names. And it's pretty sad, actually.
In the late 90s, pharmaceutical companies reassured the medical community that patients would not become addicted to prescription opioid pain relievers, and healthcare providers began to prescribe them at greater rates. This has contributed to the current crisis out on the streets, along with heroin.
Yes, definitely our most vulnerable population. We've been working very closely with our community and other service providers. We've seen almost 2,200 visits with 283 unique individuals. We've had 44 overdoses and no deaths.
Like at this present time, I'm like lost in addiction, obviously, but I'm trying to work through it to get better. I don't know. This is all right because everyone can like be around each other when they do it. That's the one thing that I can suggest that is
Safety in numbers.
Yeah, that's because if someone sees someone go down, you think they're just going to let them die? No, humanity is worth more than that.
In Surrey, Dean Atwell, Joy TV News.
Now, Keith, I'll start with you. We are hearing, and we've been talking a lot about this thing called fentanyl. Now, it's in the news a lot lately, but I think many of our viewers may not know exactly just what it is. And so maybe you can sort of explain that for us and why it's so popular.
Fentanyl is for chronic pain. Usually people that are palliative will be prescribed fentanyl. Originally, it's just come in patch forms, and it would be transdermal. You put it on your skin, it would be time release. When it got into the hands of our addicts, youth, primarily at the beginning, they would cut them up. They could put them on tinfoil and huff them. There's many different ways that they could use them. But the high would be so extreme. They get very, very high and then literally crash out. Almost like they're passing out, which is what the overdose is all about. You have to be very careful with the amount that you're actually doing it. Yeah. And because they're not set up to actually using it at all, it's very easy to overdose on this drug.
And does anyone at the table know just how much you're able to consume at the point just before it kills you? What's the lethal amount?
Okay, so I have something to say on this. Okay, when you're cutting up the patches, you can do a strip maybe that big before you start.
It's like a grain of salt.
Yeah, like a little tiny patch, like that big. Anything over that, you're asleep. You're asleep, and if you're lucky, you wake up. When it comes to the pill form, I haven't actually had any experience with the pills, but I know people that have been crushing them up and putting them in with their cocaine, with their stuff, because it does still have that addictive function to it. So if you throw it in with some cocaine, more people are gonna keep coming back to get your cocaine, because it's better than anybody else's on the street. So it's being used as kind of a tag for that too.
Yeah. Now, that video was just sort of talking about supervised injection sites, and I would be remiss to not bring them up at this table. They're controversial because A, they're taxpayer funded, and they have been viewed by some as a green light to consume an illegal drug and flout the law.
So our organization is Addictions and Mental Health Ontario, and we are not, our providers are not providing supervised injection sites yet. Many community health centers are in Toronto and in Ottawa and in other places around Ontario. And the purpose of the injection site is to ensure safe use. So people are going to use. People are going to use under very unsafe circumstances. And so they're a life-saving measure. And you can't work with someone and help them become rehabilitated if they're not alive. So that's the rationale behind supervised injection site. But I was at the pop-up injection site in Moss Park a few weeks ago, and I met a young woman there, well, actually probably an older woman there, who had a horrific story of trauma and abuse in her background and how she ended up on drugs, and she had a difficult story. But she was now using once a month and was going to counseling at a local hospital. So people can make change, and that's the advantage.
Keith, do you have, do you share sort of what Gail's views, or?
No, but I do respect them. I'm an abstinence-based individual. I don't believe that any form of drug use is good drug use, whether it's once a week, once a month, or once a year, because the side effects can still be there. I can still overdose. There's cause and effect when it comes to my family, perhaps, when it comes financially. If you are an addict, you can't use. And when it comes to these safe injection sites, I feel that they've, once again, gone about it the wrong way. The help needs to be there prior to opening something up for individuals to go to actually go there. And when I talk about the help, I mean treatment facilities for them to go to that they don't have to wait 3 to 6 months to get into. Psychiatrists and or counselors that they're able to see right away. That's a big problem when it comes to our medical system.
Stephanie, I know you have something to say about this.
I know.
There are those that, like Keith, that might argue that it's inadvertently normalizing this and not actually leading to harm reduction, because what is safe about injecting heroin? What's your perspective?
See, now I think these sites are actually helping more people get better. Whereas I actually know somebody who was looking for help, got told he couldn't make it for 3 weeks, that there was no beds available for him for 3 weeks. He ended up dying before that 3 weeks because he was still using. So instead of leaving them to die, how about we give them a place where they can safely use while they're waiting to get into those treatment centers? You're actually saving more lives.
One of the problems with what you're saying, though, unfortunately, is people need to have a period of abstinence before they get into treatment facilities. Most treatment facilities that are government-run don't have a detox facility attached to them. So you'll go into something similar to at St. Joe's, where you go to withdrawal management. However, you have to make sure there's a bed first available for you to get in there. And then you need to be clean of your substance, usually for 72 hours, prior to getting into any government facility. This is very difficult to do under the current system that we have. That's a big problem. So even if we do have these facilities for people to use, there's nowhere for them to go if we don't have all of the other things set up for them immediately.
Right, but at least they're staying alive while they're waiting for those things to be set up. What you're talking about with new rehab centers and all of that stuff, that costs money. That needs funding. People have to put that together.
And they still have to pay for all these pop-up facilities as well. We have to pay for it somehow.
But it's actually cheaper. But I think cheaper. It's cheaper than actually running for treating somebody with HIV or Hep C. It's $250,000 a year. Do you know it's only $150,000 to run one of these harm reduction programs? You're actually keeping the people alive until we can get your model working.
I mean, I think both what you both are saying is that good healthcare, requires a continuum of services, and we need services like safe injection sites for a certain segment of the population. And you're right, Keith. We do need our treatment facilities need an overhaul. We need a better, a better process in terms of withdrawal management, in terms of treatment beds, in terms of even looking at at treating addiction.
When we come back, are opioids the only viable option for pain relief? We'll discuss.
And with medical marijuana, as far as a pain relief or anything like that, unfortunately, we don't have the evidence to state that it will do the same thing.
A lot of these overdoses are happening from people who were prescribed the opioid. They're not just people at street level. How is the government tackling that specifically and tangibly?
Well, again, making sure that more services are available and training is available for prescribing medications. With respect to doctors, we certainly have to look at that. I know that when we look at the profile of consumers, sometimes it's individuals that started with prescription medication, but we can see that the profile is different from case to case. So we have to certainly address that situation with respect to the prescription use. But also we, again, have to do a lot of work when it comes to providing the services that people need, and that is really our priority.
Should it be changing what we're prescribing?
Are you saying that the doctors are not properly trained to prescribe?
Well, I'm not saying that. What I'm saying, however, is that we want to make sure that the proper information is given to ensure that everyone that is dealing with the situation can certainly get the help they need, and that's really at the end of the day what our focus is and what our target is with today's investments.
That was Federal Health Minister Jeanette Taylor at an event in Calgary where she announced new federal government activities to address the opioid crisis. Among the steps announced, first, Ottawa will support the testing of straight drugs like fentanyl at supervised injection sites to ensure that they aren't laced with toxic substances. Second, it'll seek to reduce regulatory barriers that prevent addicts from accessing prescription-grade heroin. Third, it will work with the provinces to open temporary overdose prevention sites. And fourth, it'll support pilot projects to provide safer opioid alternatives, such as Dilaudid. Now, I know a fair bit about Dilaudid. Both of my grandparents were on Dilaudid in the months just before they both passed away. And it's not pretty. It was very hard to watch. But nonetheless, what do we make of the government's proposal, Anita?
Well, I think that we have to be careful that whatever we do is evidence-based. I think that's part of how we got here in the first place, is that we've prescribed things without knowing that, does this really work? Is there a good body of evidence that supports that this is going to be safe for our population, it's going to be better. And I think that whenever we talk about legalizing something, we have to recognize that legalization can take away one set of problems, but bring another set of problems with it.
Can we just stop prescribing opioids? Is there a suitable alternative? Could we just simply take them off the market?
Well, I think that there is a role for opiates. I think that there's a limited role. I think we have to look at, as physicians, very carefully how we prescribe it. So screening our patients, is this somebody for whom an opiate would be appropriate? Do they even have a condition for which there's a good body of evidence showing that this might actually help them? Do we keep our doses reasonable? Are we monitoring them while they're on it to make sure that they're not getting into difficulty? And then if we do discover that there's difficulties with it, either maybe the opiate's simply not effective for their pain condition and they're not actually experiencing relief. Perhaps they're not addicted, but they're having serious side effects to it. So they're sedated or they're severely constipated, or perhaps they do have an issue with having developed a tolerance or psychoactive effect to it. Then how do we have a reasonable approach to plan to taper the patient away off of the opiates and move them away towards a different treatment plan?
My boss often says to me, why isn't medical marijuana an equal alternative?
It's certainly something that I've heard being promoted, and it's an alternative that needs to be explored.
Mm-hmm. Yeah. Stephanie, I know you mentioned that a little bit earlier, that would be something that you supported.
I actually do support it because I have my medical marijuana card. I was on anti-anxiety meds when I first started the Suboxone, but there's a reaction between the Suboxone and my anti-anxiety meds that could have killed me. My heart could have stopped at any given time. Isn't that nice to know? So they put me on, they gave me medical marijuana. And this is something that I've seen actually help a lot of people when they're coming off of these kind of drugs. There is so much going on up here that yes, as much as it's kind of a switched addiction, and I'll admit that right off the top, that yeah, you are using something else, it does make it that much easier to deal with the problem, like what is actually creating the addiction for you. Because I believe it's a symptom. Addiction is a symptom, not as much as a disease, but it's a symptom of something underlying that's going on. So if you can take care of that problem, then you can get rid of the addiction.
Keith, I know you don't agree with any of that. but there are people that are legitimately in crazy amounts of pain. What's the alternative here?
The alternative is actually dealing with the pain, not prescribing things for the pain.
But how do you deal with leg pain without some sort of prescription? Tylenol?
No, you can use non-narcotic, non-addictive medications. It may not give you that extreme amount of zero pain, but if I can take it down to 80, I'm functional. I have osteoarthritis in my spine. I take nothing but Advil. Okay, some days I can't put my shoes on and I know that it's extreme pain. Well, you know what? If I bend, if I do yoga, if I do things to help it, to move it along, rather than simply pop a pill to try to mask the pain will still be there, the problem will still be there, and all I'm doing is masking it. We have to start dealing with the actual issues. And with medical marijuana, as far as a pain relief or anything like that, unfortunately, we don't have the evidence to state that it will do the same thing. It will help in some ways, but will it do the same thing? We don't have that yet. So that's another portion that we're rushing into too quickly.
I would absolutely agree with Keith. I don't think that we have the body of evidence to support the use of medical marijuana. And I would say, yes, I've heard lots of people say anecdotally that it helps them. But I think that, for me as a physician, I really have to rely on the science and the body of evidence. And I don't believe it's there to support the use of medical marijuana, except for in some limited cases, such as severe neuropathic pain or chemotherapy-induced nausea and vomiting. There are a few indications for which there is some moderate evidence.
I came across a U.S. trial that was conducted by a professor at Albany Medical College, and he found that a combination of Tylenol and Advil worked just as well for pain relief as opioids in an emergency room, and this is for people that have moderate to severe pain. April, what do you make of all that?
We've grown up with this mindset that a pill is the answer, is the be-all, right? So when people think about pain, we think of Tylenol and Advil, because I'm with you. I'm kind of shocked by that study. Yeah. I'm like, wow. So when we think of pain, and if pain is severe, people don't think that a Tylenol and an Advil will be as effective as an opioid.
Mm-hmm. Okay, there's more after the break. Stay tuned.
People being able to go to multiple doctors and get multiple prescriptions and then filling them at different pharmacies. So I wonder if the panel could speak a little bit about that and how that contributes to the opioid crisis that we're facing.
Welcome back. We'll hear from the audience now, starting with Jessica. Welcome to the roundtable. What's your question?
Well, something we're hearing a lot about actually is people being able to go to multiple doctors and get multiple prescriptions and then filling them at different pharmacies. So I wonder if the panel could speak a little bit about that and how that contributes to the opioid crisis that we're facing.
Mm-hmm. Doctor shopping.
Well, I think that that used to be much more of a problem. We have a narcotic, at least I'm speaking for Ontario, we have a narcotic monitoring system now. It's not necessarily in real time, so if a patient is in my office and I'm writing them a prescription, I don't have access to that information. But when they take the prescription to the pharmacy, the pharmacist should be able to see if they've been prescribed something by another physician recently by looking in a database.
Yeah, does that database exist in the provinces? I know BC has something called PharmaNet, I think, and it links all the pharmacies so they can track who has what prescription, and that's for many things, not just so that people can go to different pharmacies and different doctors and get a million different prescriptions of Oxy. It's also to ensure that the cocktail that they're taking isn't lethal. So does that exist in other provinces?
I think it might exist in Alberta as well, but as a lawyer, I can say that you need different legislation than we have here in order to be able to do that. It's not just a question of technology and linking up databases, it's a question of consent and things like that.
We lag behind here, unfortunately, in Ontario for a lot of different things. And it used to be very big. The doctor shopping was one of the biggest things. They would see 3 or 4 different doctors at walk-in clinics at any given day. And walk-in clinics, unfortunately, were notorious for this because the same person wouldn't see the same person, 2 or 3 times a week. So clients would be able to walk in, get any prescription that they would like after self-diagnosing and telling you exactly what is wrong with them. Both addicts and individuals with real issues are very good at telling doctors exactly what they need, particularly these days with the advent of the internet. So it is something that we need to be more aware that it does still happen. If we can have things more real time, right? The moment that a prescription is filled out, either it's scanned into a computer, it's put it with your health card when you walk out. You know, you hand your health card to the receptionist swipes it and says, here's the prescription. Instantly, it's out there. So I'm not walking next door to another doctor and saying I need a prescription for the exact same thing.
Okay, well, thanks, Jessica. Thanks for your question. Welcome to the round table. And what's your question?
My question is, what do we do about emotional addiction?
So, that's right. We've spoken a lot about a physical dependence, but not an emotional one. But what is an emotional dependence?
Well, it's the belief that I need this particular substance in order to carry on. So it may start with a physical problem, such as back pain or leg pain or whatever. And then, as Keith described, after a certain amount of use, you don't know whether you've got physical pain or not, but you believe that you need this. You need this, and whether it's, an opiate, as we've been discussing, or alcohol or other kinds of drugs, it's an emotional dependence or a psychological dependence that says, if I stop using this, who knows what will happen?
I'm all about treatment. I think that the more that we can talk, the more that we can flesh things out, the more that we can get to the surface and understand exactly what's going on underneath, and then I can help you get that breakthrough. And if there is a medication that you need now to help get past that, we can prescribe it safely and know what's going on. But sometimes we don't even need anything. We need somebody to talk to.
All right, well, stay right there. We'll be right back with some final thoughts in just a moment.
Regarding the opioid crisis, Mackenzie tweets his frustrations. These safe injection sites will promote drug use and allow for health issues to rise. The safe injection sites are not beneficial for Canadians, but in fact detrimental to their health. I believe the safe use of illegal drugs should not be promoted by the government. And on Facebook, Tyler shares his personal experience about the need for safe injection sites. Some of my friends have been hooked for years, he says. Call them addicts or whatever you want, but I've seen far better results at supervised injection sites than people doing it alone in their homes. Thank you for the feedback, and for the latest news and full episodes, visit www.thezoomertv.com.
Welcome back. We'll hear some final thoughts from our panelists. Now, starting to my left, Keith.
I think one of the biggest things that we need to look at is addiction is an ugly subject that nobody wants to talk about. And because nobody wants to talk about it, unfortunately, nobody wants to put any money towards it. All right? We can simply get away with it. They're dirty people, they're bad people, they're all of these various things. What I look at is we need to get real government funding towards treatment programs, either harm reduction or abstinence-based programs, whatever the individual chooses, but we need to get the programs up and ready for these people. This fentanyl opioid crisis that we have is very real, and it's going to take a lot of lives unless we do something about it immediately.
Anita.
Yeah, so I agree with what Keith said. I think that we are dealing with a big crisis, and my big issue is access. I really think that I would like patients in the rural regions of our country to be able to have access to good treatment. We've talked a lot about things like safe injection sites and treatment centers, but I would also really like to find a way to let people stay in their home communities and receive good treatment at home in their primary care setting. And I believe we have very good evidence-based medications that are already covered, that are available, and that should be available to people in their home communities. And I think we have a lot of the resources to do this, and I believe that is going to be the wave of the future, and that's going to help us address the opiate crisis.
You're right. Dr. Anita is talking about really looking at how to support people in their home environment, right? I mean, treatment centers are great, and we also know that we have amazing resources you know, in our province, throughout the country. And I think you know, these conversations help, right? Let's keep having these conversations. My colleague agency, CMHA Ontario, I'm going to do a shameless plug, did a great resource that came out this month about, you know, reducing harms, recognizing and responding to opioid overdoses in organizations. And it's a free toolkit for community agencies, not just mental health and addiction agencies, right? Community agencies, I would argue, places where people are, to really make sure that, you know, one of the simple things we can do is even have naloxone, right? At bars, restaurants, like have a first aid intervention to deal with this opioid crisis as well.
These are fathers, mothers, sisters, brothers. These are people. I know a lot of people look at an addict and see somebody that's, like you were saying, that's a horrible person or a thief, a criminal, something like that. And I think we really need to start taking a different look at these people, because this stigma is what's keeping them from actually going to get the help sometimes. Like, I know I have 4 kids, and I was always told that if they find out you're an addict, they're going to take your kids from you. So I'd like to see that stigma go down so people will be more open to going and getting the help that they need, whether it be an abstinence-based program or a harm reduction program, because everybody's program is different. So I would like to see that stigma go away so that people would actually start using the programs that are available.
Really good point. I think the stigma and fear is huge, and that's the reason that we haven't had, for example, base budget increases to addiction and mental health agencies for over 8 years. So you lose capacity when that happens. And we do need the full range of treatment options out there so that people can stay in their home communities and get the treatment they need, including better support for family physicians so that they can provide these services, because many don't have that, as well as the residential community treatment, withdrawal management. All of those services need much better support. We're starting to get that. It feels like we're beginning to make the point. It needs to continue. It needs to continue to support these. Right now in Ontario, the health budget, only about 6% to 7% of it is spent on mental health and addiction services. The recommended level from the Mental Health Commission of Canada is at least 9%. And in other countries, it can be 10 to 14%. So we really need to look at increasing the resources to the helping professions and the services that are out there.
Okay, well, as always, thank you to my expert panel for being here, and to the audience in studio and at home. We'll see you next time. For now, it's time to zoom out.